One of the things, fever is actually a pretty important characteristic of this. 43% of them on admission, about 88, I think about 9% doing hospitalization. That kind of helps us stratify some of these patients here. Cough, 67%. Diarrhea is actually very low. That's a good thing to keep in mind, because the problem is that most of these patients, what is that? Go ahead, they have fever, cough, and shortness of breath. That's a ton of people. This virus tends to cause pneumonias. This is not unexpected. But you want to kind of maybe keep in mind that nausea, diarrhea, and report are fairly uncommon to try to stratify some of these patients. Intubation is around 4 to 5 days. Most people get symptoms. Just about everybody has symptoms about 14 or less days. There are a few people that do have symptoms past this, very few. So that's why the 14 days tries to help. That's where this 14 days self-isolation comes from. But most people 4 or 5 days. And yes, you can infect others during the incubation period. You don't know how effective that transmission is. Most viruses, such as the flu, you can transmit it, but it doesn't. You can't transmit it as readily as you can when you have full-blown symptoms. So that's just something to keep in mind. We don't know if that applies to this virus yet. Probably does. On admission, so you got one big thing is, since this virus causes pneumonia often, CAT scan is very common to see infiltrates with a lot of ground glass opacities. And these people tend to do worse. Severe cases, only 2.9 did not have any CT changes. About 18% also did not have any non-severe. So a lot of times you do have changes on a CAT scan. And the problem is we can't get CAT scans in everybody, which is tough to do. And then you have to clean the machine, unless you get between each one, which takes a lot of time. So that's a big problem with this. So it's not like we can just get CAT scans to everybody that comes in the hospital. Lymphocytopenia was present at 83%, which I think this is something we may need to keep in mind when trying to figure out who we test, what do we do with these guys. So biggie, GI symptoms low, fever, cough, and shortness of breath is the main ones. Lymphocytopenia and ground glass opacities and CAT scan. But once again, we can't get CAT scans. How often do we get CAT scans in a regular someone comes with pneumonia? Not often. Some epidemiology, this is scary. Got this from Ray yesterday, from hospitals, American Hospital Association. Basically, you can see that ICU cases 1 to 2%, hospitalization 5%. That's a lot of people. 4.8 million people in admission, 1.9 ICUs. So, and there was, the mortality is maybe 1%, which may not be, maybe higher than that. But this is what we concern about. These people taking up beds, taking up PPEs, resources, isolation, possibly getting healthcare workers sick. This number is scary. 480,000 deaths. I think that's saying if it's 10 times severe, it's a little, it may be worse, may not be. But this number could rise. So there's a lot of people saying, oh yeah, you're healthy, you're young, you don't have that huge chance of getting bad things. That's true, but for a healthcare perspective, these people are in the hospital. They take up beds. These take up beds that people with heart attacks, strokes, cancer, that what we need. So that's a big problem. Transmission. Okay, we hear about this everywhere. Mostly droplets. That means that's generally believed to be about 3 feet, maybe 6 feet. You sneeze, you breathe, it gets on a droplet, and it falls on the floor. Okay? And then, medically speaking, airborne is it kind of floats in the air. You can sneeze, and it kind of floats, and someone else walks past and breathes it in. That's kind of the medical definition. We're not 100% sure it's airborne right now, but we do airborne precautions. That's what the CDC recommends. The WHO is a little more lax on the airborne precautions, but the WHO overall gears the recommendations for resource-poor countries that don't have N95 masks, don't have airborne. So generally speaking, when they make the recommendations, they usually look at more resource-poor countries. But, you know, we may become that, we may run out of N95 masks. So anyway, so right now, we recommend, and the CDC recommends, gown, glove, N95 mask, face shields. Contact with infected fomites, such as the surface, you see that and touch your eyes. We don't know how effective this transmission is, but right now, it's definitely something we got to be concerned about. Don't touch your face. If you're touching elevator buttons and door handles like everyone does, this thing dictating into a dictaphone, your hand may be contaminated. So basically, when it gets in your eyes, ears, and mouth. So that's what we're trying to avoid here: eyes, ears, and mouth. All right. Other coronaviruses have been known to infect animals. We do not know if COVID virus, the SARS-CoV-2 virus, is transmitted this way. But ironically enough, the CDC says if you're self-isolate, you should isolate yourself away from your pets. Just leaving that out there. But this is not known right now to be the source of transmission. All right, so no one has to run out, swab their dogs, or leave the dogs outside. Right now, you know, studies are pending, but it seems to be a little bit more infectious than the flu. Have you heard anything different, John? That's about right. Okay. Risk factors. Okay, so who's this population that does bad? Did you hear on TV? You know, lately you're trying to calm everybody down, saying, "Oh, you got 0.000% of die." That's probably not true. But these people that do bad are people equal to or greater than 60 years old. Kidney disease, lung disease, heart disease, and over here they got diabetes. Any sort of chronic medical conditions. And, you know, these are, I wrote them as risk factors. They're not really risk factors we know in guidelines. They're not studied, there's no odds with it. Like I said, this is all evolving rapidly. So if someone has like high blood pressure that's controlled, some mild heart failure, they're going to do better than someone with uncontrolled heart failure. Yeah. So there's always there's a lot of stuff. There's a lot of clinical judgment that goes into this. But we all know patients that fit in here that's going to do bad. And that's where the mortality is. These are the people that go to the ICU. These are the people that we're here to try to help out. And you know, it's not here, but if someone's immunocompromised, that's an issue. They're probably going to do bad. I don't think the study yet, because not things are studied, but these are the things that have been pointed out. This is the group, especially this age group, 60, 65, is right when the mortality starts really taking off. And obviously most of our patients are already like that. Severity. Okay, so this is the big thing. Right now, case fatality rate is anywhere between 2.3% to 3.6%. That was published by the WHO last week, about a week ago from today. And that's kind of high, but they also did say the population has opinion. This is based on some population testing right now. They're still pending. They got to go out and just take asymptomatic people's blood with IgGs and IgMs to see where we wind up. They've started doing that, and the mortality rates really may be somewhere around here. We don't know yet. This is WHO. This is the most recent one that they come by the other day. And once again, they said big population test opinion. When they did come out, there's one interesting thing they said was that right now, it looks like there's actually very few asymptomatic cases, which is good in the sense that maybe it doesn't spread as much as we thought it did before. But that, on the flip side, that jacks up our mortality. All right, so here's some different statistics. Okay, some of these statistics do contradict each other a little bit. Oops. Mild symptoms, 2-week recovery, 81%, and 14% severe, 3 to 6 weeks, 5% are critical. You know, then so you hear on TV, well, you know, you kind of get the impression sometimes when you hear on TV, oh, you're either going to get a little cough, or you're going to die. And most people are going to get a cough. But there's actually a middle ground that comes to the hospital, as we all know, doctors, and they do go home. And I think we got to sometimes remind some people that they're not invincible. If you're healthy and you're young, you'll probably do fine. But there are some people that do bad. And so there is a middle ground here. And this is, you know, these people are in the bed for a while. We'll get to that in a second. Transmission. Okay, so this is a hot topic. Who gets it, who doesn't? So the CDC kind of defines close contact is basically about 6 feet for a prolonged period of time, such as, caring for somebody, well, that makes sense. Living with somebody, right? Healthcare waiting area, waiting room, okay? So waiting room. So you don't need all day to be around somebody. But it's also walking past somebody at the grocery store, you're okay. Unless down here, you get sneezed or coughed on. So this is the brief exposure. So if you get sneezed or coughed on right away, that's considered close contact. Walking past somebody in the street, you're okay. Walking past somebody, if they're wheeling a patient past you that somehow doesn't have a mask on and they breathe on you, you're okay. Now if you're examining them, if you're swabbing them, if you're intubating them, you're not okay, even if it's a brief period. How long is a brief period? We don't know for sure, but this is what they have laid out. But we need to keep this in mind because we're going to probably be walking past these patients, and you're going to hear about people saying, "Oh, my mom, my son went, he saw this kid that had diagnosed with it, and he stood with him in line or something." And this is going to come out. So, and also you can calm people down because I'm sure your relatives asking y'all. I walked past somebody today. They didn't look well. Or maybe had stereotyped somebody. Let's throw that out there. All right. Kind of talked about this. Diagnosis. The CDC changed their guidelines up, and it's very vague right now. It's very vague. Before they said, someone that came into the country. Yes, obviously someone comes up from Italy, South Korea, China. That's the problem. But now we've got Washington here, all around. And the symptoms themselves are like, well, what symptoms? Fever's a good one. But fever may not catch everybody. But fever should catch the severe cases. So who do we stress? Well, the CDC says you've got to use your clinical judgment. They just kind of left it out there. So this is a big problem. We had somebody in the ER yesterday. Fortunately, we found out it probably wasn't, and we looked at, Dr. Ferguson here, and took a great travel history and found out they got sick here and not where they went to. But this will come up, I'm sure Rowan can attest to this, probably come up tonight, tomorrow. We don't know. We really don't know. Someone with a viral pneumonia. Who do we test? Somebody with a viral pneumonia. That's the best we can say right now. They have an elevated procalcitonin level, and for once I think I'm actually encouraging people to get procalcitonin levels. Sorry, Barry. But if it is elevated, remember that which higher it is, more likely to be bacteria. Okay, this tends to have a low procalcitonin level. And lymphopenia, like we said before, lymphocytopenia. So those are things, and we're going to have to use our clinical judgment. And then the question is, do they need, just because you have COVID-19, they don't need to be admitted, okay? They can be sent home. All right, I'm kind of jumping ahead, but they can be sent home. If they need to be admitted for just regular reasons, hypoxia, sepsis, then they should be. So how do we diagnose them? Okay, so this is kind of vague, and we haven't worked through it, and we're waiting for the CDC to give us some guidance. We can call the Office of Public Health, right down here. This is the phone number, okay? So if we get somebody we think needs to be tested, how to do it? Well, Quest said, when the president said everyone's going to get tested, guess what? That's not true. Quest said they would go live Monday. Well, they did in 3 states, not here. I heard earlier today that LabCorp is supposed to be helping us out. Well, maybe. We need to talk about that, and that may be something we need to get. But either one of these turnaround times is 3 to 4 days. Okay? That's 3 to 4 days. If we miss somebody, that's PPEs we're wasting, the room we're wasting. We don't have a lot of PPEs. So the public health can turn around less than 24 hours. But in order for that to happen, you got to call this number. It has to be approved, and they may not approve it. Yesterday, did they ever return phone calls? No. They said they were returning phone calls. And I don't want to make light of it, but in a lot of ways, we're on our own with this. And that's the kind of the conference call I got earlier today with LCMC. We're kind of on our own. So anyway, that's what we're supposed to do, is call this number and get a swab. think it's somewhere else, but I'll just go and tell you. What we need to do, it's a PCR, I think it's right here. So right now, it's swab your back of your nose, back of the throat, and if you can produce a sputum. I don't know if it's necessary, that's what the Office of Public Health wants right now. I don't know if that's necessary for all this, or this is just them studying it, coordinating, seeing if these tests all line up. I don't know, that's what they want. Obviously sputum, that's plus or minus, they're not producing anything. But this is what they want. And if they do, if they smile upon you and they do say yes, we'll give you the test, they'll get a carry. We order it as a miscellaneous test. The medium is the stuff we already got in for other viral stuff. So we already have it. We ordered as a miscellaneous test in the computer. And we're supposed to obtain it in a negative pressure room. And then our micro lab, is my understanding, will coordinate it with the public health. When they call us back, they carry, bring to Baton Rouge, and then they'll turn around in a few hours and let us know right away. So obtaining it in a negative air room is kind of interesting because the Office of Public Health also said a lot of this should be obtained by private in offices. Doctor's offices, keep them out the hospital. How many of y'all have airborne isolation office? A lot of this, like I said, does not jive. Anyway. So back to the symptoms, severe progression. This is interesting, and this is something we need to keep. If we send somebody out who said they're not infected, or because the problem is these are the people that do kind of that. First 7 days, pretty good. They worsen about week 2. And you need to tell them that. Just say, if you get worse, you have to call the hospital. You have to call us back. You need to talk about it. Okay? So around day 7 is when the admissions really start coming in. These many people kind of get sick. 51% day 8. And then right around the ICU admission around 10, 11, and then in the ICU here. The average person that's with a severe infection usually is discharged around day 20. The ones that die around day 21. Okay? That's roughly 14 days here of a acute care / ICU bed that we don't have. If they survive, they don't survive. That's them, us gowning up, throwing away face masks, it's a whole nother story. So this will gum up the works. Even if they make it, this gums up the works for all the other patients that come in routine surgeries and heart attacks, strokes, everything else. Treatment, support. Okay, for right now. Avoid steroids. Apparently in China they love steroids, and they found these people do bad. They shed more and their mortality rate is up. Now, we pretty much limit steroids here for patients that are in severe septic shock. I don't know how that goes with this. If someone is tanking, I would use some steroids, try to get them out, and get them off the steroids as soon as possible. It seems like China likes to put patients on steroids for most viral illnesses, not necessarily for people that are doing bad with septic shock. So I don't know how to rectify this in my mind, but I would say if someone really needs it, they're doing bad, put them on steroids, pull it off as quickly as possible. We need it as quickly as possible. Remdesivir, this is when you hear about, they're investigating right now, we don't know how well it works. Lopinavir, ritonavir, this is an old HIV med. Actually, we got some patients on this too. This is around everywhere. They don't know if this works either, but apparently it kind of worked in MERS, so they're testing this out. This would be wonderful if this works. And they're trying a few other HIV meds out because we got plenty of this stuff around. And Actimir, maybe we're saying it wrong for your rheumatological people. I think this is for treatment of rheumatoid arthritis and a few other sort of things. Apparently, it's approved in China for the treatment of it, and it blocks interleukin 6. There's a cytokine storm that happens toward the end of this, in the severe cases. So, there's no recommendations here. And I imagine this is something really expensive. I don't know. It's a monoclonal antibody. These tend to be very expensive. I don't know yet. I mean, as soon as we get more guidance, we'll be happy to share it. On a side note, I was looking up to about well past midnight because they kept on getting some information on some things last night. I was trying to update this thing. Didn't get it all on here, but some of the patients that do bad, about 50% of them get other infections. So that's something to keep in mind. So antibiotics may play a role in the super infections. But for right now, it's mostly supportive because this is a viral pneumonia. You know, flu kind of causes some flu viral pneumonias, but a lot of people get staph and strep pneumonias and die from that. This is usually a primary coronavirus pneumonia, but then like most patients, when they start getting sick, they get other infections. So I'm going to try to hurry up here. Things on admission that shows people doing bad. SOFA score. I did a plain talk, so you can look online real quick. It's actually, we have it listed, I think, on our surviving such as PowerPoint with the SOFA is. Higher SOFA scores, worse you do. D-dimer of all things. Greater than 1 tends to show people that do bad. I thought that was very interesting. So if you think they have it, probably procalcitonin level, D-dimer, we should probably do D-dimers. And age, we already talked about that. This is the D-dimer. The blue, people that do good. People that don't do bad. These are the people that don't live. You can see the D-dimer, really big, 7, 10, really start going up. So you can kind of stratify who's going to do bad. This is lymphocytes. The survivors can have higher lymphocytes. This is CR. This is high sensitive CRP. Not surprised the guys that do bad that die goes up. And this is lactate. Not surprising too. I mean, you can see it starts off bad and they do really bad, and the ones that survive goes down. But I think D-dimer is important to keep in mind when taking care of these patients. These will let you know who's possibly do bad, and of course the lymphocytes. Oh, when you get